Okay. Hi everyone. Today is the second class for radiology. Yesterday we saw about how X-rays are being produced, the radiation physics behind it, the biology, safety and protection. So today's class is going to involve, once the X-rays are produced, the next step is going to be capturing it, right? So to capture X-rays, basically we need something called as receptors. We need to receive the X-rays to give it as a visual image for us to view and diagnose it. So for these receptors, we have two main types, okay? So I hope the screen is visible for you. So it is going to involve the conventional films, the one that we use traditionally. Both it is going to involve both your intraoral and your extraoral films. When it comes to your conventional films, the composition, the way in which it absorbs the X-rays, everything is going to be the same. Even the processing is almost the same, right? For the conventional films, be it intraoral or for the extraoral ones. When it comes to the digital X-rays, we call the films as sensors. Okay, these are the digital sensors that are going to capture the incoming X-rays and give you the final image to be viewed on the monitor. So when it comes to the conventional films, both for intraoral as well as the extraoral films, it exists in three main speeds. Okay, D speed, E speed, and F speed. Among these three, E speed is the most commonly used one. Okay, the D speed and F speed films, if you see the difference based on the shape of the crystals, we will differentiate the films as different types of speeds. Okay, I will explain it to you in detail in the forthcoming slides. Moving on to the digital sensors. So when it comes to the sensors, we have two main types, a direct imaging and an indirect imaging. So the direct imaging is going to involve your solid state detectors. Under that you have your charged coupled device, your complementary metal oxide semiconductors, and your flat panel detectors. The indirect one is going to involve your PSP, that is your photostimulable phosphoplates. I will be explaining each one in detail for you in the forthcoming slides, okay? So moving on to the first category, that is your conventional films. So let's have a look at the parts of the conventional film. This is your IOP film, you all know, right? So when you open the packet, your X-ray film packet, first you'll be seeing the outer plastic covering, then you'll have a black color sheet, and then the black color wrapping is basically to protect it from getting pre-exposed to the visible light, okay? And you have your lead foil, and then comes your X-ray film. So when you look at the microscopic section, you will have different parts of the X-ray film. And the next picture you can see is for the extraoral films, okay? When it comes to extraoral films, we make use of something called as intensifying screens, which is placed on either side of the X-ray film. And all this thing is encased within a cassette. The cassette basically is to have the intensifying screen in place and then wedge it between the X-ray film. Okay, the X-ray film has to be in between an intensifying screen on either side, and then it will be enclosed within a cassette. This is mostly for your OPG, your cephalogram, your skull radiographs, all the extraoral radiographs. Okay. So this is the components of your X-ray, components as in parts of your X-ray film, intraoral and extraoral. Next thing is looking at a cross-sectional, that is in the microscopic view. When you look at the cross-section of the X-ray film, be it both intraoral and the extraoral, get it clear, okay? You have something called as an emulsion, okay? The main composition is your emulsion and the base. So this emulsion will be coated on either side. That is why it's a double emulsion thing, okay? You have the base in between and emulsion on either side, which is attached to the base with the help of an adhesive, okay? So this emulsion will be a double emulsion layer that is coated over the base, and then it will be fixed to the base with the help of an adhesive, okay? And then the outer covering is called as the super coat. So this emulsion is made up of silver halide grains. Like we all know, the basic chemistry of halides. Halides contains three main things: chlorine, bromine, and iodine. When it comes to the X-rays, it is specifically bromine. So these silver halide grains are going to be silver bromide grains in case of your X-ray film. This is the emulsion. This emulsion will have the silver bromide crystals scattered here and there. Okay, so it will be coated with that. So depending on the shape of these silver halide crystals, this will determine the speed of the film. Okay, so they can be either flat, tubular, or globular in structure. So when it comes to your D speed films, initially what they did was they kept the silver halide crystals to be globular in shape. I'll show you the picture here. So the second picture, if you see, no, these are like globules, right? This is in case of your D speed film. And the first picture is flat and tabular. Okay, so this one is in the case of your F-speed film. What happens is when the crystals are globular in shape, what will happen? It tends to absorb the X-rays on from all the directions. And when you compare it with the X-rays absorbed in case of your flat tabular crystals, if you have a flat surface, what will happen? More X-rays can be absorbed, right? If more X-rays are absorbed, then the exposure time can be minimized. So ultimately, what will happen? We get more X-rays in a shorter duration. But in case of a globular crystal, the structure is something irregular. So what will happen? It can absorb only here and there. The X-rays will be absorbed. So the X-ray absorption is lesser when compared to a flat surface. So invariably, the exposure time is going to be increased in case of your D speed when compared to your F speed. But all the advantages will have disadvantages also, right? Anything that has an advantage will have a disadvantage. So when you compare the flat tabular structure with this globular one, although this has a reduced exposure, one drawback is the film contrast or the image sharpness or the resolution. If you see, these things tend to be decreased when it comes to your F-speed films. That is why they are most commonly not in use, and your D-speed films tend to have a higher resolution when compared to your F-speed films. So, but since because it has another drawback of increased exposure, they had something in between. That is your E-speed films, the most commonly used one. If you take your Carestream X-ray box, no, it will be written E-speed films there. So it is between your D-speed and your F-speed films. These crystals have an optimal X-ray absorbing capacity, and they also have a optimal resolving power. That is the image sharpness. So that is why they tend to be used more frequently in case of your intraoral and your extraoral films currently. Okay, you should know that there are D, E, and F speed films, the shape of the crystals. What is the advantage of having a flat tabular crystal and what is the disadvantage? We should know all these things. Okay, so next thing is your vehicle. That is your vehicle is going to absorb your processing chemicals. This emulsion will absorb the processing chemicals, allow it to reach the silver halide grains, and we have something called as an overcoat, I told you, right? This will protect the X-ray film from any kind of mechanical damage or an external damage. Okay, so this vehicle is like to absorb the chemicals and helps to process the X-ray film. Once after exposure, these silver halide grains will absorb the X-rays and all, right? It will give you the latent image. Then finally, it has to be processed. So this vehicle will tend to make the absorb the X-ray processing chemicals, help to develop the film, and also prevent it from any kind of external damage. Okay, so now the main hero, that is the base of the film. So the base only has emulsion on either side, right? So this base is made up of something called as PPT. Okay, polyester polyethylene terephthalate. Remember, polyester polyethylene terephthalate. So this base has to be slightly flexible. It cannot be very rigid, otherwise the placement of the film is going to be difficult for you, and it can be more prone to damage when you place it more lingually and all. No, if you have to slightly bend the film and all, right? So in such cases, only if it is flexible, it will be more convenient for the usage for both the doctors as well as for the patients. And apart from being more flexible, it needs another property called as chemical inertness. The reason why it should be chemically inert is you're going to place it inside the oral cavity in case of your intraoral films. So it should not interact with the body fluids, especially your saliva. So it has to be chemically inert and translucent, because if it is opaque and if it has some other particles on it, what will happen when you try to process it and view it under the viewer light? It is going to interfere with the image formation. It is going to be slightly clumsy, right? So you will not be able to give the get the proper diagnostic quality. So it has to be translucent, flexible, and chemically inert. These three should be the properties of your base of the X-ray film. When it comes to X-ray extraoral X-ray film also, obviously it is the same. So that is why I mentioned you already. The parts of the conventional X-ray film and the composition is going to be same for both the intraoral and the extraoral X-rays. It contains silver halide, especially the silver bromide grains in the emulsion, and the base is made up of polyester polyethylene terephthalate. Okay, so a few questions related to that. The photosensitive component of an X-ray film is, and they'll give you four options: silver halide crystals, sodium thiosulfate, gelatin, and rare earth elements. The obvious answer is your silver halide crystals. So this is the photosensitive component, as in your silver halide grains are going to be sensitive to the X-ray photons that are emitted out of the X-ray tube. It is going to absorb it and then help in the image formation. Okay. So the answer is silver halide grains. The reason why the others are not relevant is sodium thiosulfite is a component that belongs to a fixer solution. Gelatin is the base in which the silver halide crystals are suspended, and it cannot be radiosensitive because it is the vehicle there. Okay, so I forgot to mention the name there. So the vehicle that I was talking about is the gelatin. Okay, and rare earth elements are parts of intensifying screens. We'll see how they are going to help in the intensifying screens. Okay. So yeah, it is important that the base should be opaque, rigid, flexible, completely clear, and sensitive to X-rays. The answer is very clear here, right? Obviously, the X-ray film they should be extremely flexible. And the other answers, if you see opaque, no, we saw that it should be translucent. Rigid, no, the opposite is flexible. It has to be flexible. It cannot be completely clear because it definitely has the other components on it, right? So it won't be completely clear. And it should not be sensitive to X-rays because you have silver halide grains on top of it that are going to be sensitive to the X-rays and help in the image formation. Okay. All right. So the next question, the added film overcoat protects the film from the damage from all except one. There are four options given for you. First thing is scratching. Yes. Mechanical scratching, it is going to prevent from any kind of mechanical damage. Contamination. Yes. When you're going to place the film within the processing solutions, it has to prevent from any kind of contamination. Processing errors, obviously not, right? So when you're processing it, there is not going to be any kind of change from the overcoat. The overcoat does not have any kind of interference with the processing errors. So option C should be the answer. The last one is automatic processor roller pressure. Yes, definitely. Your overcoat has to be flexible and it has to withstand the pressure when it is passing through the automatic processor, right? So all the other options are correct except for option C, that is your processing errors. Okay. Yep. So looking at the orientation of the X-rays. So initially we'll first see about the intraoral, then we'll talk about the extraoral films. Okay. So when you look at the intraoral film, we have something called as a white surface, which is going to place towards which is going to face the tube side, and the other surface is going to be having a folded end, that is the blue color end, and then you have the outer wrapping. So this white color surface, no, it has something called as a raised dot or an orientation dot. So this one helps you to position the X-ray intraorally. Okay. So when it comes to IOPA films, the orientation dot always should face the occlusal surface. Okay. It should face the occlusal surface, and placing the white surface towards the side of the X-ray tube. So when you orient it, for example, if you're going to place it in the third quadrant, that is your lower left side. Remember, I have seen many of them placing the X-ray films on the buccal side. There is no purpose when you place it on the buccal side. It is something like, imagine your X-ray source to be something like a light. Okay. When you have a light, you need the object. When you need some shadow formation, what we'll do, you have the light source on one side, object in between, and then you'll keep the wall or a paper on the other side to receive the shadow. Similarly, your X-ray source on one side, your object should be in between. Object is your tooth, and then you have your X-ray film. So the film has to be placed behind the tooth. Never place it on the buccal aspect. I've seen many people doing that, but never do that. Okay. X-ray film has to be placed behind the tooth or the object which you're going to capture. So the X-ray will come from this side. Your white surface of the X-ray film, you can see, right, with the orientation dot. With the orientation dot towards the occlusal surface. If it's maxilla, then it's going to be down. If it's mandible, it's going to be placed upwards. Okay. Orientation dot towards the occlusal surface. White surface facing the tube behind the tooth. Okay. Behind the tooth, you'll be placing it lingually or palatally. And then you'll be exposing the film. This rule will apply the same for your occlusal radiograph also. Whenever you're going to expose your maxillary teeth, no, you'll be placing the orientation dot obviously towards the front side, and then you'll be placing the X-ray film in such a way that the white color surface is facing towards the tube. You're going to expose it from on top, right, for the maxillary occlusal X-ray. So X-ray tube will be placed here. Your film will be placed in such a way that the white surface is facing the tube. For the mandible, if you see, you have to place the white color film surface facing downwards, and the X-ray tube will be placed in such a way that it is going to go and hit on the white surface. It is going to be placed above the teeth. I hope you can imagine white surface facing the tube, and X-ray tube is going to be projected from here. Okay, so this is the orientation of your X-ray film. Okay, so different sizes. Your periapical films comes in three different sizes, but the most commonly used one is your 31 into 41 mm. Okay, that is the standard adult size of your X-ray film, and you can see it varies for the pedo films. That is your pediatric films, the child projection size 0 and size 1. And then your bite wing radiographs, most commonly we use the same periapical film, that is 31 into 41 mm. The same IOP film, we'll be using it for the bite wing radiographs. And then comes your occlusal film. Technically, if you see, occlusal film has to be it's almost 3x of your periapical film. So the size of your occlusal film is around 57 to 76 millimeters. Okay. The reason why I've mentioned the sizes is it can sometimes come in MCQs, or they might ask you in Viva. Okay. The size of the X-ray film. Remember the size of the periapical film? Your bite wing is almost the same as your IOPA film. And remember the size of your occlusal film. Okay. Okay, this is an example of a self-developing film. Okay, we need processing chemicals, right? In case of a self-developing film, what will happen is it will have the processing chemicals. This part is rare. This tab kind of a thing is there. No, this will be exposed to the X-rays, and then you will have processing chemicals on the other side. So when you try to squeeze the chemicals onto the X-ray film, and then you have to press it nicely, and then when you pull out the film, it'll be developed on its own. You need not dip it into the process, the developer or a fixer, and then get the image. It is an example of a self-developing film. It is also commonly used nowadays, but then since it is cost effective, we don't use it on a daily basis. Yeah. Moving on to screen films. See, when it comes to your intraoral X-ray films, no, they are mostly direct imaging technique. As in, you're just going to have the film, expose it, process it, get the image. There's nothing in between to prevent any kind of scattered X-rays or anything like that. But when it comes to extraoral films, right, like your OPGs, your cephalograms, your skull radiographs, we need or we make use of something called as screen films. These screen films are not direct films, but they are indirect. The reason being, they tend to make use of visible light. Okay, they tend to make use of visible light to absorb the X-ray photons, and then this visible light, it will get converted to visible light, and this is going to expose your X-ray film. Okay, like I'll just tell you how it happens with the help of a picture. Yes. So as you can see this picture, right? So what will happen is you have this cassette with the intensifying screen on either side. You have the X-ray film in the middle. Okay. So what will happen is you place the X-ray film, close the cassette, and place it on the side of interest for you. And then the X-rays are going to come from the opposite side. So these X-rays will go and hit on the cassette on the intensifying screen, and then only it is going to go and reach the film, but it is going to reach the film in the form of visible light and not as direct X-ray photons. How this conversion takes place is with the help of your intensifying screens. So what this intensifying screen will actually do is it will absorb the incoming X-ray photons, convert it into visible light, and this visible light will go and expose the X-ray film, expose the silver halide grains present in the X-ray film. Okay, so the reason why we need this is because in case of your extraoral radiography, no, sometimes what happens, there is going to be scattered radiation to the other regions, and there's going to be low energy photons also absorbed, right? So in such cases, what will happen, it is going to result in film fogging, image unsharpness, and everything. So to prevent this scattered radiation and low energy photons from affecting the diagnostic quality, we tend to use this intensifying screens. Apart from this, one other biggest advantage is it is going to reduce the radiation exposure. We know this intensifying screens are sensitive to visible light, so we are trying to make use of this intensifying screen to convert the X-ray film into X-ray photons into visible light, and then we are going to expose the film so that the radiation exposure to the patient is very much reduced. Okay. Whenever there is an advantage, obviously there is going to be a disadvantage. So this intensifying screens, a disadvantage of it is it has a reflective layer. Okay, so what happens is this reflecting layer will tend to induce some kind of backscatter. So because of that, it tends to create some amount of low resolution capacity and an image, a little bit of image unsharpness. Okay, so this is a disadvantage why we don't make use of intensifying screens in the intraoral X-rays. And also it's not necessary. It is a very small area that is going to be exposed. We have this collimators, positioning device and everything, right? So intraoral films, it is not needed. But since there is a disadvantage of using intensifying screens, we don't try to use it, okay? In the intraoral X-rays. But in the extraoral X-rays, it has a major advantage. We have to see the risk versus benefit, right? So the benefit here is it is going to reduce the X-ray exposure, and it is going to reduce the backscatter or the low energy photons and everything. So the disadvantage is it can contribute to some amount of image unsharpness. So we don't tend to use it. Okay. So when you look at the composition of your screen films, it consists of a base, a phosphor layer, and a protective coat. So this phosphor layer is made up of certain rare earth elements. See, the reason why this color is important is some screens tend to be sensitive to any kind of a particular light. Some screens will be sensitive to green light, some screens will be sensitive to blue light. Okay, so depending on the sensitivity of the screen, we tend to coat the intensifying screen with the that particular rare earth element or a phosphor element. For example, if the screen is sensitive to green light, then when we need a green color emission, green color light emission, then we have to use a gadolinium oxysulfide, which is activated by terbium. When we need a blue light, we should use a yttrium tantalate, which is activated by niobium. Okay, so these phosphor crystals will be coated by this rare earth elements on the intensifying screens. Okay, so this will try to emit that specific light to which the screen is sensitive. If the screen is sensitive to green light, means this intensifying screen should be coated with that particular rare earth element, then only it is going to emit the green light. So this light emission, if you see, no, this emission has to be equal to the absorption of X-rays. The energy of this light emission should be equal to the absorption of the X-ray photons. Okay, so it has to match. The absorbance and the emission should match, then only we will have a proper image. Okay, and one more thing is, if there is a mismatch between this screen and the film, for example, you're using a blue color sensitive film for a green color intensifying screen, for that one, if there is a mismatch, then we have an artifact, something called as a mottling artifact. Okay, so there's going to be a mismatch between the wavelength of energies and then a wavelength of that light, and then the image quality is going to be definitely not proper. Okay, it's called as a mottling artifact. That's why you need a proper screen film combination. Okay. So comparing the screen film intensifying screen combinations with the direct exposure film, it reveals that the screen intensifying screen combinations render resolution, require more exposure, require special processing chemistry, preferred for intraoral radiography. So with this, I hope you know the answer clearly, right? So the correct answer is actually rendering less resolution. It definitely does not require more exposure. That is why we are using it in extraoral radiography to reduce the X-ray exposure to the patient. Second thing, it definitely does not require any kind of special processing techniques. Third one, it is not preferred for intraoral radiography because of reason A only. Okay, it renders less resolution. That is why we don't use in intraoral radiography. Apart from that, there is minimum exposure only. That is why we don't use it in intraoral radiography. The correct answer for this particular question, they are actually trying to compare the screen films with the direct exposure film. In all the options given, they're asking you which one is correct. Only the first one is correct, because option B, C, and D are not relevant to it. Okay, so rendering less resolution. Yeah, the dispersion of visible light from the crystals, that is in the phosphor layer of your intensifying screen, will cause reduced image resolution when it is compared to the direct exposure, that is your conventional IOPA film. Okay. So one more question that was asked was, if intensifying screens help to reduce the patient exposure, that is the X-ray exposure, Which reason best explains why they are not used in intraoral imaging? It's almost similar to the previous question only. We are telling you that, yeah, we are telling an advantage that the intensifying screens tend to reduce the X-ray exposure. But why is it not used in the intraoral imaging? And they're giving you four options. They intensify the X-ray beam, they are unaccommodating in size, they reduce the resolution of the image, they require increased source to object distance. I hope everybody will know the answer here. They reduce the resolution of the image. See, the other options, unaccommodating in size and all, is not much more relevant. But since they have this quality of reducing the resolution capacity of the image, we don't use it. It's going to compromise your diagnostic quality, especially in your intraoral periapical films and all. No, you must see the apex clearly, and then you need to visualize the surrounding structures. It's just not the tooth and the bone that you're going to see. Sometimes you will have to look at the PDL very clearly, the lamina dura, the trabeculae. All these things have to, these fine details only give you the diagnostic quality, right? So if this resolution capacity is compromised, then definitely your diagnostic accuracy will not be there. So that is why we don't make use of this intensifying screens in case of your intraoral films. Okay. So which is the disadvantage of a reflective intensifying screen base? And one more thing, when I say about the reflective property, not all intensifying screens have a reflective property. Okay. Sometimes they are available as a with a non-reflective layer. So a material called as titanium oxide has been used to coat on the phosphor layer to make it reflective. Okay. So which is the disadvantage of a reflective intensifying screen base? Augments visible light, increases light emission, results in image unsharpness, requires longer exposure time. See, what happens is you have two intensifying screens on either side, film in between, right? This is going to absorb the X-rays, emit visible light, and going to expose the film. Sometimes what will happen is you have another intensifying screen on the opposite side. So when this is coated with a reflective layer, this will tend to reflect the light again to the film. So because of that, what will happen is it will lead to image fogging, film fogging. Okay, so that is why this is the main disadvantage of using a reflective intensifying screen base. Okay, so the answer is option C. It results in image unsharpness. Oh yeah, this one I just told you. The reflecting material that is used in the intensifying screen-based material is your titanium oxide. I did not mention it there. I'm just make a note of it here, okay? Titanium dioxide is the material that is used in the intensifying screen base as a reflective material. Okay. One more thing, when we are studying about intensifying screens and everything, we need to know something called as grids. In case of IOPA films, these grids, intensifying screens, they don't have a major role. When it comes to larger portions like skull, chest X-ray, your abdomen X-ray, and all those things, no, these grids have a role. Okay, so what happens is we know something called as Compton scattering, right? The X-ray photons will go and hit on the outermost electron. It will tend to deflect the income electron from that orbital. There's going to be scattered radiation, all that, right? So this grids help to remove that scattered radiation caused by Compton scattering. Okay, so because of that, what will happen? Um, Whenever there is scattered radiation, there is going to be loss of image sharpness and contrast. So when this grid is placed, it will help to remove the scattered radiation and improve the image sharpness and contrast. Okay, so what is the composition of this grid? Basically, it is made up of alternating thin strips of lead, and okay, that is a high density material, and something that is a radiolucent interspace, which is mostly involving aluminum or a carbon fiber. Okay, there's going to be alternating strips of lead and aluminum or a carbon fiber. Okay, a high density material, a radiolucent material, high density material, radiolucent material. Okay, so there's going to be alternative strips. You can see in the picture here, I hope, right? Lead strips and the radiolucent material in between. And this is basically placed in front of the image receptor or the X-ray film. Okay, and these grids are available in two main types. One is the parallel, second is the focused. In the parallel type, the lead strips are placed parallel to each other and it is very good for the short distance exposure. In case of the focused, the strips will be slightly angulated and they are converging towards the X-ray source. Okay, this will match with the divergent X-ray beam, and it helps to prevent absorption of the primary beam at the center. Okay, so this will help in better capturing of the scattered radiation. Okay, so parallel and focused. Remember, in the focused, the strips will be angulated, converging towards the X-ray source, so that it is going to match with the divergent X-ray beam. Your X-ray beam is going to be divergent. This will be converging towards the divergent X-ray beam, so that it is going to have an increased absorption of the scattered radiation. It will better capture the scattered radiation. This is about the concept of your grids, mostly used in case of your extraoral radiography, not in intraoral. Excuse me. Yeah, this one I think I already told you about the orientation of X-rays. And this for the extraoral X-rays, obviously, the X-ray film is going to placed in between, the cassette is closed, and you'll have a surface on the, plain surface on the cassette, on which you can, for the conventional ones, no, we need to know which is the left and the right side, no? For that, we will try to fold the lead foil or the lead paper, and then we'll make a marking like L. So when it is exposed, this L-shaped thing will be visible as a radio opaque structure on the extraoral film. This helps to orient your side of the X-ray. Okay. So this is about the orientation of the X-rays. Yeah. So now we saw that X-rays are formed, X-rays are captured. Now we have to see how the image is being formed, right? So you have the receptor, X-rays are going to go and hit on it. It is going to create some kind of an invisible image. This invisible image is called as the latent image. Only when you process this invisible image will you get the final diagnostic image. That only you'll be able to see. Okay. So this X-rays, everything is invisible, right? It's nothing is going to be visible to our eyes. So X-rays are going to be invisible, going and falling on the X-ray film. You're going to get some kind of a background or a scaffold or an invisible image. This invisible image is called as the latent image. Okay. So the silver halide crystal is that, or the silver bromide, it will be present scattered on the X-ray film. And what happens is whenever the X-ray photons are being absorbed, it will try to create something. See, one more thing that I wanted to mention here is the silver halide crystals, they will be coated with silver particles. Okay, so this one it will try to create some kind of an irregularities on the X-ray film. Okay, so whenever there is going to be X-ray photon absorption, this irregularities will tend to create something called as sensitivity sites. Okay, so these sensitivity sites, this will be negatively charged. The incoming X-ray photon is going to be positively charged. I mean, the incoming X-ray photon is going to come and create this sensitivity site that is negatively charged. And what will happen? You have silver halide scattered here and there, no, and free silver ions scattered there. So these will be positively charged. So this positively charged silver will go and get trapped towards the negatively charged sensitivity site. Okay, these are the silver part ions are positively charged. The sensitivity sites are negatively charged. So this will go and get trapped there. So electron trapping is going to take place. Okay, what will happen is the next thing is going to be whenever there are more X-ray photons absorbed there and all, there is going to be more amount of silver ion migration. Wherever there is less amount of X-ray photons captured or no X-ray photons captured, there and all that silver particles will not be there. Okay, so basically that is the concept. Whenever there is X-ray, more amount of X-ray absorption, there the sensitivity site is going to be more amount of silver deposition. Wherever there is no absorption, there silver presence is not going to be there. So finally, you've got this outline. This metallic silver is going to be spread here and there. The next step is going to be processing. Okay. So we have two types of solutions for the X-ray film processing. One is the developer and the second is your fixer. Okay. So what actually happens is when you develop this X-ray film with the latent image, when you dip it inside the developer solution, these free silver particles are there. No, it will get developed and it will result in the form of a black color film. Okay. Black color metallic silver. Oh, that is the thing there. Okay, black color metallic silver will be formed. So When you look at the X-ray film after you dip it inside the developer, it will be just pitch black. Nothing will be visible. Okay. So because all of these silver halide particles are going to combine with the developer solution, and this metallic silver is going to give you this black color image. Nothing is seen. You don't know where the bone is. You don't know where the soft tissue is. Nothing is seen. So what is the components of this developer solution? We have three main things, okay? First is your base of the developer, that is your phenidone or your hydroquinone. This one only will interact with the silver halide crystals and process that metallic silver. Second thing is your activator, okay? Here it is an alkali, okay? Basically, your developer solution is alkaline in nature. So that is why you have an alkali activator, that is your sodium or your potassium hydroxide. Then it comes with a preservative, that is your sodium sulfite. Okay. I'll tell you one more thing. This is a practical information. So when they leave you inside the dark room, no, they have two boxes. You don't know which is the developer and which is the fixer. First thing that you can do is a touch test. Just dip your finger inside the developer solution, touch and see. It'll be slightly soapy because it is alkaline in nature. When you look at the your fixer solution, it has an acidic medium. Okay, it is an acidic medium, so you will be able to smell that strong pungency of that acidic nature, and you can, it is a differentiating feature. This will be soapy because it is alkaline in nature. Okay, so this is about your developer. So now X-ray film has been dipped inside the developer. You have this phenone and hydroquinone, this alkali activator that is going to develop your black metallic silver. Okay, next thing what you'll do, you'll dip it inside the water. The reason why you're dipping in water is to remove the underdeveloped or your undeveloped silver halide grains and to stop the developing process. Okay, it is going to halt. It is going to say, developer, please stop your work. I'm going to proceed to the next one. If you leave it inside the developer solution for a long time, what will happen? It will become completely black, right? After that, even if you put in water or if you put in fixer, there's no use at all the silver halide grains will be developed, nothing will be seen. Okay, that is why you have to develop for a particular duration, remove it, place it in the water to remove the undeveloped X-ray has, I mean, the silver halide crystals. And then the next thing is put it inside the fixer. So this fixer solution consists of four main components. First thing is the clearing agent. The reason why we need a clearing agent is to remove all the undeveloped silver bromide grains. Okay, clearing agent. The clearing agent is ammonium thiosulfate. Okay. Second thing is acidifier. This is something like an acetic acid buffer to maintain the pH of the solution. So here it is acetic acid buffer. Third is preservative. Preservative here is ammonium sulfite. There it was sodium sulfite. Here it is ammonium sulfite. Okay. The last thing is hardener. The reason why you need a hardener is you have gelatin, right, in your X-ray film base. So this hardener will go and combine with the gelatin and it will fix the image onto the X-ray film. See, once you've got the image, no, after putting in developer fixer and all, this image shouldn't get washed away, right? So it has to be fixed onto the X-ray film. So this hardener will combine with the gelatin of your X-ray base and then it'll fix the image onto the X-ray film. The hardener that is used is ammonium sulfate. Okay. So this is about your components of your processing solutions, developer and fixer. When it comes to your automatic X-ray processing, it is developer, fixer, then only water. But in case of your manual processing technique, it is developer, water, fixer, water. Okay. And one more reason why we need this hardener in the fixer solution is sometimes what happens is if you don't fix the image properly, if you leave it in the fixer for a very long time and you don't wash it properly, it'll have this brown color layer on top because this hardening agent and all, everything is coated over the X-ray film, right? So if it is not washed properly, then this fixer solution will be retained onto the X-ray film. Obviously, it is going to compromise your diagnostic quality. Okay. Yeah, so the primary function of the developer is four options they've given. Reduce the crystals of silver halide to solid silver grains. Reduce the solid silver grains to specks of silver halide. Remove the unexposed silver halide crystals. Remove the exposed silver halide crystals. The correct answer is option A. The reason being, the removing of this exposed, unexposed, everything is going to happen in case of your water and your fixer. And reducing the silver grains, solid silver grains to specks of silver halide is the reverse process. It doesn't take place, right? Your X-ray film has silver halide crystals. Those are going to get converted to solid silver grains with the help of your developer. Answer A is the correct Option A is the correct answer. Okay. So all this processing techniques will take place within the dark room, right? So it has a particular equipment. So I think this dimensions and all will be mentioned in your textbook. Just remember, the GBX2 filter is the most recommended one, and it has to be at least the light source should be at least 4 into 5 feet away from the X-ray processing unit. The reason why we use this red light is the X-ray films are quite sensitive to the other light films, the UV light and all that, so it will get exposed. When you open the packet, it will get exposed. So this red light will be quite safe for processing the X-ray film. And to test the safety of if the red light is working, the red filter is working or not, we tend to do something called as a penny test. So what we do is, on the unexposed, we keep an unexposed X-ray film and a penny on top of it, and you have the red light. Okay, red light over it. Okay, so what we do is we try to process the X-ray film after like 3 to 5 minutes or 2 minutes. We try to open this packet, we'll process it and see if in case you see, as you see a shadow of that coin on the X-ray film, then it means your safety light is not proper and it's time to change it. Okay, if you don't see it, then means your safety light is working. Because what happens if your safety light is not proper, then obviously your coin shadow should not be there. No, so that is why to check the safety of the red filter, we do something called as a penny test. I think that will also be asked in Viva and also for your. Sometimes it can be asked in MCQs. Okay. Yep. This is the pictures relevant to that. Okay. Oh yeah. The purpose of the penny test is to check the proper safe lighting conditions. Option D is the answer. Okay. I think that is explained here for you. It is to check the darkroom safe lighting. It is placed on the X-ray film for 2 minutes and the film will be processed. If it casts a light area on the film corresponding to the penny, then the safe lighting is too bright and there is fogging of the film. Time to change it. So the first picture shows you the manual processing, developer, water, fixer. Second one is your this is not this is your automatic processing unit. Okay, so they'll have the developer, fixer, and the water. These black color holes are there, no? Through that only you'll be inserting your hands, and then you have to open the X-ray film only below this red color light. Okay, you should not open the film and then place it inside. It is going to be exposed to white light. You have to open the packet within this box only under this red color filter. Okay, so that it doesn't get pre-exposed, and then you'll be placing it over a rack. So this is how it will be. This is the place where you'll insert the X-ray film, and it'll have multiple racks. Okay, it'll be moving. It'll be like something like a roller. Okay, so this X-ray film will move over this roller, go inside, get dipped in the developer. Then again it'll move over it, get dipped inside the fixer. Then it'll be rinsed with water. There'll be a drying rack also. After which you'll get the X-ray film on the opposite side. This is your automatic processing unit. Okay. So, which is an acceptable film processing best practice? Slide processing, time temperature processing, overexposing, underdeveloping, following the solution manufacturer's instructions. See, basically, timed temperature processing one is the ideal one, but on a daily basis in a clinic or in a hospital setting, we cannot use it. But by textbook, if you go, the correct answer is time temperature processing. It has to be timed, and the solutions have to be placed in an optimal temperature. Then only the diagnostic quality will be much improved. Okay. Okay, so until now we saw about the conventional X-ray films. So moving on to the digital X-rays. Okay, so when it comes to digital X-rays, this person, Dr. Sir Francis Moen, was the person who discovered the digital X-rays, okay, or digital radiography. The concept is almost the same, like absorption of X-rays and everything. Instead of films there, it is going to be sensors here. But how it is getting digitized, how we are going to get the final image, how the processing is going to take place is the difference between your conventional one and your digital imaging. Okay. So when it comes to your digital imaging or digitization, excuse me. When it comes to your digital imaging or your digitization, this digitization will take place in two methods. Okay, spatial distribution of the picture elements, and second thing is your different shades of gray of the pixels. So basically what happens is, imagine your X-ray film, you have this X-ray sensor divided into grids. Okay, it has multiple rows and columns, and each of these boxes are called as pixels or picture elements. Okay, so each of this pixel will absorb the X-ray photons and then create that latent image. So for example, if you're having bone particle, means what will happen, X-ray films will get attenuated. It cannot pass through bone, right? Bone is an opaque object. So only less amount of X-rays will hit on the bone, and then it will cross and go and hit on the X-ray film. If it is a soft tissue structure, more X-rays will go pass through the soft tissue structure and it will go and hit on the X-ray film. So more X-rays means the color will be darker. A small amount of X-rays are absorbed means the color is going to be lighter. Just imagine that way. So depending upon the different shades of gray, depending upon how much of X-rays is absorbed, each of the box will be assigned with a particular number, which is going to coordinate or correlate with the different shade of gray. Okay, so more amount of X-rays, imagine it is going to be a black color box. Some amount of X-rays, white or a slight gray. Okay, so this is how this sensor is going to be digitized to give you the with different shades of gray assigned to each of these pixels to give you the final radiographic image. I'll show you like a flow chart. It will be easy for you to understand. So first step is form exposure to the X-rays. X-ray exposure is the first step. It is almost same as that. The settings, everything is going to be same as that of your X-ray film. Second step is each pixel, each square is going to absorb different amount of X-rays depending on whether it is passing through bone or whether it is passing through the soft tissue. So each of these X-rays that are absorbed is going to generate some amount of voltage. More X-rays, more voltage. Less X-rays, less voltage. Okay. So this difference between the voltage is going to create something called as a voltage fluctuation that is going to create an analog signal. Okay. So this analog signal will be read by the computer program to give you that final radiographic image. So like I told you, this voltage fluctuation, these signals, each pixel is going to be assigned a number. More amount of X-rays means, say for example, more amount of X-rays means the number is going to be 10. Less amount of X-rays means number is going to be 1. So what the computer will do is, wherever there is the signal, the analog signal is going to be 10, it will give one kind of a dark black color one. Wherever there is going to be 5 or 4, it is going to give a slighter, lesser shade of black or a lesser shade of gray. Wherever there's going to be 1 or 0, it is going to be white in color. Okay, so this is how it will assign the gray boxes inside the pixel to give you the final image. You will see radio opaque and radiolucent structures over the final X-ray image. I hope this part is clear for you. So this analog to digital conversion will take place by two steps. First is sampling, second is quantization. So I will explain the steps for you. Sampling is, you have this pixels with the values and all I told you. So the small range of voltage values will be grouped together. That is called as sampling. It is gathering everything. No, that is sampling. Second step is quantization, assigning a number to each of these values. For every sampled signal, a value is going to be assigned. Third step is computer processing. Like I told you, the computer is going to process. It is going to organize the matrix. The pixels, it consists of this matrix, no? So the pixels will be organized in the matrix according to the number that is assigned to it. And the last step is going to be the image display. So the organized pixels will display the image as different shades of gray. I hope it is clear for you. This is the analog to digital conversion. Okay. So there are two types like I already mentioned for you, direct and indirect. The difference is a direct imaging, you'll have a sensor attached to the computer itself. So once you expose the sensor to the X-ray and then it will directly give you the image on the screen. In case of indirect, no, it will have something like a mediator. Okay. This mediator is like to convert the latent image to give you the final image. Direct examples are your charged coupled device, complementary metal oxide, and your flat panel detectors. Indirect example is your photostimulable phosphor plates. So this sensor will be placed inside this external machine, and this machine will try to convert the latent image and then give you the final radiographic image. So this one I already explained to you previously itself, no? So see, the concept of CCD and CMOS is almost the same. Okay, this X-ray absorption, analog to digital conversion, everything is going to be the same. The difference comes in the place how the pixels are being read. It has to go to the X-ray unit now. After the pixels are have this X-rays and the signals, it has to go and be read by the computer. No, the way in which the signals are being read makes the difference between CCD and CMOS. In case of CCD, Each of these signals will be coupled, okay, by a bucket brigade fashion. Bucket brigade fashion is, imagine you're standing in a queue, you're having a bucket full of water. You're passing the bucket to one person, to the next person, to the next person, and then only you're going to fill it inside the well, okay. So this passing of bucket, similar to that only, these signals will be passed from one pixel to another pixel to another pixel, finally to the last computer processing unit. So this bucket brigade fashion happens in CCD, but in CMOS, each pixel will be individually connected to a capacitor. You can see, right? Each of this is individually connected to a capacitor. So it will be the way in which the pixels are being read is creates the difference between your charged coupled device and your complementary metal oxide semiconductor. Otherwise, everything's the same, okay? X-ray absorption, processing, everything is the same for CCD and the CMOS. When it comes to your, this is the bucket brigade fashion. I just wanted to describe it for you. That's it. So when it comes to your flat panel detectors, no, they are mostly used for larger images like your CT, CBCT and all. So this concept of scintillators is something that is similar to your intensifying screens. It almost just the same. Your charge coupled device is sensitive to light, so it makes use of the scintillating material to absorb the X-ray photon, convert it into visible light, and then give it to the sensor to give you the image, basically to reduce the radiation exposure. So the materials that are used for the scintillators are gadolinium oxybromide and cesium iodide. The concept is just the same as that of your intensifying screens. Okay, intensifying screens in case of your films, scintillators in case of your sensors. Okay. Yes. So flat panel detectors, again, I told you it is for larger X-rays, right? It is of two types. Yeah, it is of two types, your direct, your direct and your indirect ones, okay. So these detectors will be quite larger in size with a pixel size of less than 100 micrometers, mostly used for CT and CBCT and all that. Yeah. So the next thing is your photostimulable phosphor plates. This is a kind of indirect imaging, like I told you. And here it makes use of this concept called as phosphorescence, where the X-rays will be absorbed by this a sensor. When you place it inside the machine, this will it'll have a laser light that is going to emit phosphorescence, which is going to convert the X-ray photons and give you the final radiographic image. Okay. Yes. So you can see this is actually the thing how it will happen. So initially when you place it inside that machine, no, it will the plate will be prepared and